For me, there's probably a couple cases when I started using this implant that I think sort of convinced me or actually made me start thinking of the power of the implant. It's a 78-year-old patient, quite sick. She had severe heart disease. She was on a assist device for her heart and had this low fracture below an implant. This case was pretty impactful to me because when this patient came back, the family was sort of complaining that she's doing fine, not a lot of pain, but she seemed to be getting more and more knock-kneed. But also you can see that problem of mismatch of the size of the implant and the canal size in these old patients. It really did affect her mechanical axis. And family's really unhappy about this because it actually is affecting her ability to mobilize. In the past, you'd either sort of try to write it out or you would, think about trying to do something about it. But, the question is, how aggressive to be in a patient like this. We decided to go forward with a revision. And this is where, again, this case, it sort of showed me the power of IlluminOss. The nail is mobile in the canal. That shouldn't be surprising to you. There's not dense bone in these old people's canal. And so here what I did was I just ran the IlluminOss up the lateral condyle next to the nail. And again, we could do this with really minimal footprint, which is sort of cool for this patient. This idea now of getting interlock through some better substrate distally sort of flicked a light bulb for me about this implant in this patient population. And here she is post-op with that nail centralized, improved frontal plane alignment, I think. And I do have later follow-up. I had 3-month follow-up on her, and she's going on to unite this pretty uneventfully. And actually, this idea of not only being able to control implant position in the canal, but also, there still is some reliance on bone with nails. Everybody's like, oh, nails are the answer for elderly people. Nails still rely on those interlocks for some biomechanical function. And the bone down at the distal femur, especially these periprosthetic ones, is really terrible.
Interlocking options, obliques, washers, fixed angle, whatever it is. But again, just like anything else, it's highly dependent on the bone that, those interlocks are going into. And so you did a really nice job of keeping this, of the IlluminOss, adjacent to the nail. But I think there's just a ton of opportunities with this device, especially in some of these challenging fractures. So nice job.
So this is like a nightmare. 67-year-old, non-union. This was what was fixed in our place. They put a fibula in there, and this is what it came to me, like, everything floated away and resorption of bone and the screws fell down low in the arm. And I sort of staged it with this construct, which gave up. And then at 6 weeks, he had this clinical appearance and he'd pulled his plate off, but his labs were normal. And I didn't think that was infection. I just thought that was irritation from the plate. And so then I did this retrograde, antegrade nailing approach to stabilize his humeral shaft using a nail. Canal implant mismatch now in the upper extremity. It's swimming in there. You can see that he's got erosions around those distal locks. So instability for sure, right?
Nothing fills zero. There's not a single titanium implant that fills that canal distally.
Totally. But I knew that I wanted to get stability here. So we actually inserted a new nail, and then we ran another IlluminOss down medial to that nail. So dual implant. Now I can get canal fill stability because I have the IlluminOss that I'm going to inflate medial to the nail and spanning that gap. And so this is the final reconstruction. And again, their cool image of the implant in the fracture gap of his arm. Here he is, allograft DBM packed around that and a more stable situation. Here he is 3 months post-surgery. He's having no pain. It feels stable. In fact, he's starting to go to PT and he loves showing that, he's doing pretty good moving that arm. I just saw him a few weeks ago at 7 months. That implant hasn't moved a millimeter, nowhere. You can feel that feel of the drill going through the implant, through the polymer. And so it's actually, again, pretty satisfying. So I've been thinking about all these ways that I can use it where I used to use things like allograft or other augmentation like fibula, for example. And I think, that's an idea. Here's a fracture, just a pretty simple, low torsional, elderly distal tibia that I can nail it, but it's nailing for nailing's sake, not for the patient's well-being. So, we did a prick reduction and then we just ran the implant up the canal. So now intramedullary augmentation. So this is not a nail, but then it's actually coming with a medial submuscular or subcutaneous plate. There's post-op. Again, to me, I'm more satisfied now with control than I am with the nail. I've always said, like, God, I wish I could inject cement or sulfate or something, like, even though I'm fixing them with like how I fix young patients, but I know I'm still relying on the substrate, which is terrible. This is a weird thing. So this is a patient that my partner sent to me, had an FNS and a shaft. I told him I thought it was infected, so he debrided the shaft, did a temporary antibiotic plate, and took off the FNS. This is a year after injury. And then she came in and said, my groin is actually hurting. You can see there's a problem at the femoral neck after a year. And you can see neck non-union, but look at the size of that defect from the FNS. But it's taken out a lot of bone. She's 25. Neck non-union, cavernous defect in the head.
Yeah, I mean, this is
You know,
a
like a simple everyday case, right?
yeah, yeah, exactly.
Anyway, so before I would try all the stuff like dowel, bone dowels, or fibula, or impact grafting, but look at that defect. That's like really hard to get a fill. And so we decided I compressed the neck with some screws and then set it up for a realignment osteotomy, a valgus IT osteotomy. And so we went subtroch to give a little space between the osteotomy cut and the implant entry site. Now I'm thinking about using it more. People are like, oh my gosh, the same questions always, right? How are you going to get it out? What if it gets infected? Well, what if I impact 12 pounds of allograft in there and it gets infected? How am I going to get that out? Or if I put a fibula in there and it gets infected? So, I mean, I get people's question, but also it's like, I'm also trying to achieve some mechanical success in some ways. And so,
Yeah, for sure. And I think one of the, one of the advantages, if you kind of go back to some of the things that we were talking initially about, that I know make the hair on the back of your neck poke straight up when we talk about plate and nails, but one of the challenges there is that every time you start putting some of these other devices in, if you're using a plate around a standard trauma nail, you have to figure out how to avoid that implant. This is just a way of saying, look, I want to fill that space. I want the benefits of dual implant, but now I can use a hook plate or a proximal
yeah,
femoral locking plate or something like that. Like, around the time that I was kind of introduced to IlluminOss, I had this string of either geriatric humeral shafts that were either managed non-surgically and went on to kind of floppy upper extremities, or similar to one of the cases you showed, it was some revision situation where how am I going to stabilize this upper extremity, especially in the humerus where there's a lot of torsional forces. Intramedullary devices kind of in isolation weren't necessarily satisfactory. So I like the idea of being able to dock screws from a plate into something and using it in areas where you might have otherwise used a fibular shaft or something like that. And the number of times that I've sat on the back table and tried to chisel and craft a hemicortical tibial allograft or something like that just to fit it in the intramedullary canal and whatever, just that was getting tiring. I thought I'd show a couple more recent cases of where it's provided some benefit, I think, to my common practice. So 62-year-old female, fall from standing height a week ago. Patients who come in with these lateral compression injuries, and for sure I've had my fair share of just using implants in the posterior ring, and I would say mild to moderate overall happiness with with how that works out for me. So I think the anterior ring is really pretty critical to this, just getting this back into a better spot. But we have patients who have anterior ring morphologies that just don't accept a straight implant. Her bone quality is horrific for being a 60-some-year-old. Used some implants in the back, but then got her front lined up. Look how small that superior ramus is on the left side. And so I'm trying to figure out, can I get a straight standard orthopedic screw across that? Made a small incision, using a short IlluminOss into that, across that oblique fracture. This really does a nice job of strutting this out. So she had fixation in the back, fixation in the front, and then I just let her walk on. These, right? So she's got robust implants in the back and fixation in the front. 64-year-old, obese, had a fall 6 months ago, but continued to have kind of groin pain and difficulty ambulating. She actually has a non-union of the left superior ramus as well as the inferior ramus. Even though she doesn't have a lot of deformity, she has instability there and it's symptomatic. Fixed her up in the back just to stabilize her posterior ring, find my start point. And I like using the awl. I think the awl is really powerful and it helps you really guide the implant in your trajectory exactly where you want it. And then after that, I just inflate it, utilize this to stabilize her anterior ring, and then this is what she ends up with. So I think you can, anywhere that there's a pathway for bone, there's an opportunity if needed for this.
these are awesome examples of like that. That's a crazy tough path to navigate, and you just made it happen. So that's cool.
As a 96-year-old female, has fall from standing height. She was transferred in, ton of medical comorbidities, and she's got a history of falls. And so this is her initial X-rays at the outside hospital. She can see she's got a hip stem above, and has this simple intra-articular injury below. She was, a week out, and she was quite short, and so started distracting her. again, small incision on the lateral side, but was able to slide a long implant up. But trying to figure out the fixation in this patient's, poor bone and how I was going to, manage the implants. This was a kind of a perfect IlluminOss case in my mind. Small incision on the medial side, entry into the medullary canal, and then you can see the guide wire that just goes up. Thinking about kind of two column stability or intramedullary device and a plate, thought this was going to work pretty nicely, because then I'd be able to just dock anything I wanted to into that IlluminOss.
That medial column is completely disrupted. Like, if plate alone, I would have given you about a 20% chance of having success with that thing staying in place. I mean, this is right on the mechanical axis. It's so logical once you think about it.
So get the implant up, and actually we were able to take the implant a little bit past where the hip stem was, and then just fill the canal and just docked everything distally into the implants. I was very happy with this. It was completely stable, and just let her walk on it immediately afterwards. 1 month, and she's been weight bearing as tolerated. She came back in for something else, but has been walking on this and is overall doing very well. So pretty happy with this. 37-year-old, severe rheumatoid arthritis with right hip pain. The patient's going to get a hip replacement. I know that they've got implants all over the place that have multi holes and whatnot, but this patient is not that old, but her bone is horrific. We looked at her CT scans. You can see her posterior column. She's got a chronic non-union there, and then she's disrupted through the anterior column, kind of right through where her head is disintegrated, and she's got some issues. And so the anatomy was pretty challenging. In kind of our pre-planning, I thought this would be a good opportunity for an IlluminOss through the anterior column. So at least he had something to ream into and then put screws into if we wanted. And then was able to pass the guide wire ream. And then I just plated the posterior column, and then he put screws back up into that and actually caught two of the IlluminOss with these big, monster cup screws that go, the kind of these cancella screws that go through the acetabulum. So this is what it looked like. So anterior column stability, plated posterior column, and then the hip. And then we just saw her back not that long ago. She's actually doing really well. And we let her weight bear immediately on this because the cup had great stability, and I had kind of two column stability around it. So kind of a interesting application. That was a fun one because it worked pretty nicely. So